My name's Thomas Hunter. I'm one of the orthopaedic consultants here at Wrexham. Here we have a selection of short videos for information for patients who are coming for their joint replacement surgery. We know this can be quite a daunting time for patients, so we've tried to get as much information as we can for all the different aspects of staying in hospital for your operation, as well as what happens afterwards.
Today we are going to talk about what it is to have arthritis, preparing for the surgical treatment for arthritis, what to expect in the hospital and at home, and how to deal with the physiotherapy. When the arthritis is limited to one part of your knee joint, you could have a partial knee replacement. The advantages of partial knee replacement is better function, less pain, and better long-term outcomes. Obviously, each patient will need to be assessed whether they are compatible for a partial knee replacement. So we'll talk about who needs a partial knee replacement. When the arthritis is limited to a part of the knee, then you may be a candidate for a partial knee replacement. The knee replacement is to replace the worn out cartilage in the knee. There are three reasons you could need a partial knee replacement. Number one, you have got worsening pain which is not controlled by regular medications, including paracetamol, naproxen, ibuprofen. If you are having too many medications, then you may be a candidate for a knee replacement surgery. The second reason would be deteriorating function. So your mobility might have reduced, your walking distance would have reduced. Going up and down the stairs might be a problem for you. Walking with walking aids, that might be a reason of limited mobility as well. The third reason you may need a partial knee replacement is when all the non-operative options are exhausted, like bracing, physiotherapy, weight reduction options, and activity modifications. So what is partial knee made up of? It's made up of a metal cap which fits onto the thigh bone, a metal plate which fits onto the leg bone, and a bearing which is made up of plastic in between the two. So what kind of knee replacement could you have? You could either have a partial knee replacement or a full knee replacement. It depends on the type of wear that your knee has. If the wear pattern is limited to a certain area of your knee, you may be a candidate for a partial knee replacement. The advantages of partial knee replacement are better functional outcome, better recovery, and lesser pain after the surgery. What happens during a joint replacement surgery? The damaged joint surface is exposed surgically, the arthritic bone is then removed, and then we implant the artificial joint into the knee. And after that, the wound is closed and dressing is applied. Many patients ask me, how does the joint fit onto the bone? So two ways of fixing the implant to the bone. One is with cement, and the other option is go without cement. How do I prepare for the operation? So you need to avoid any kind of infections around your body. You need to keep yourself clean and drink plenty of water. You need to have some dental checks before the surgery if there are any issues, and stay as active as possible. What we call as rehabilitation, to keep your joint moving so your muscles are toned and the recovery is much faster following the surgery. You need to optimize weight before the surgery. Weight reduction is a good option, and if you reduce your weight, the complications following the surgery are reduced as well. The other things you could control is your other medical issues like hypertension and diabetes. Keep your skin clear of any cuts and bruises. If you are on blood thinning tablets, then we will stop them before the surgery so that you don't have much bleeding during the surgery or after the surgery. and have support afterwards. Get your family members and friends to help you after the surgery, because recovery does take quite a long time. If you smoke, that can increase the chance of infection. You need to stop smoking before at least a month before the surgery. You need to learn the exercises before the surgery so they're easier after the surgery and improve the recovery of the knee joint. What happens on the day of the surgery? You arrive at a designated time. You're admitted by the ward staff. There's a lot of paperwork that needs to be done, and theatre checklist need to be done as well. So keep enough time for that. You'll be seen by the surgical team as well as the anesthetics team. The type of anesthesia will be discussed with you before the surgery, and the pros and the cons of each type of anesthesia will be provided to you. The surgical team will check the consent form for the surgery, and they will mark your correct limb for the surgery at that time. If there are any questions regarding the anesthesia, this is your time to ask the anesthetist about it. What happens after the surgery is very important. The recovery period is the crux of any surgery. The better the recovery experience, you will have better functional outcome. The main issue is organization. So organize your home and your family. The family needs to know when you're going to come to the hospital and get admitted and when you're going to get discharged, so that they have got enough time in their diaries to help you out. Sleep is an important component of recovery. Take good painkillers so that you can sleep better. If the sleep is disturbed after the surgery, you will have poor experience and your functional recovery may not be as good. Make sure you organize your bed. Find out how many stairs there are to go to the bed and down, and whether you could manage it. If possible, get the bed downstairs so that you have got enough room around the bed to get in and out of the bed. Make sure you got enough pillows to prop yourself up and underneath your legs so that it's elevated. Painkillers. It's quite important to be on top of the pain. If you take painkillers, you will have better functional outcome because you will be doing more physiotherapy after the surgery. The more painful the joint is, the less physiotherapy you would be doing, and that can stiffen up the joint. Make sure you take regular painkillers, be top of the pain, and take them as prescribed. Icing is an important component of recovery. The knee joint swells up quite a bit after the surgery. Ice helps in reducing the swelling and reducing the pain as well. If ice is not available, you can use frozen peas and wrap it around a towel and put it on the knee for about 10 to 20 minutes twice a day. And that will make a huge difference. Make recovery your job. It's very, very important to know what the timeline is after the surgery. The wound itself takes about 2 weeks for it to heal. The swelling will take about 4 to 6 weeks for it to go down. The range of motion will be about 90 degrees at 6 weeks, and this will improve day by day after that. You need to take care of your surgical wound. The sterile dressing that you get after the surgery needs to be kept clean and dry. Try to minimize any change of the dressings. You will have a compression bandage after the surgery which comes off in a day or two. The clips or sutures on your skin will come out in around 2 weeks' time after the surgery. Most of the patients with partial knee replacement are discharged the same day of surgery or the next day of surgery. Most of them go home after the surgery with help of crutches, which comes off in about 2 to 3 weeks' time. After discharge, you will have a follow-up at around 6 to 8 weeks' time with the consultant or a nurse practitioner. A following follow-up will be also arranged for you at about a year's time, where you will need further x-rays to make sure everything is fine. You will also be invited in outcome scores, which helps us to determine how well you're doing after the surgery. You'll also be invited in physiotherapy clinics for physiotherapy after the surgery. This is essential. Many patients ask us, when can I get back to driving? There is no set time as such. Once the pain and swelling goes down and you are comfortable and safe to drive, you should be able to drive. Usually, it takes about 6 to 8 weeks after the surgery, and the general advice is ask the surgeon after your first follow-up. Work, it takes about 6 to 12 weeks to go back to work. It also depends on what kind of work you're doing. If it's a desk work, then you may be able to return to work earlier. Sports and hobbies can be commenced again once the swelling and pain are down and as you're able to do them. One important part of recovery is talk to other patients. They will tell you how important it is about physiotherapy, how their experience has been after the surgery. Thank you so much for listening to me. I hope you have a great journey ahead.
Hello, I'm Dr. Fiona Nelhans and I'm one of the group of orthopaedic anaesthetists at the Wrexham Hospital. I've been asked to do just a quick overview of what to expect from your anaesthetic for your hip or knee replacement surgery. So what can we going to cover? I'll have a chat about the anaesthetist visiting you in the morning or day of your surgery. We'll have a look at your anaesthetic choices and we'll go through pain relief during and after the surgery. On the day that you come into hospital, your anaesthetist will come and visit you on the ward. There will always be a senior anaesthetist in charge of your list. They may have a trainee with them. One of those two will come and see you beforehand. The main focus of the visit will be discussing your medical history and any medical conditions you may have and how they affect you in particular. From that, the anaesthetist will be able to make a judgment as to which form of anaesthetic may be more suitable for you. They'll have a look at the medications that you're normally on and discuss which ones you have taken that day. And then they will discuss with you which anaesthetic is best for you and what will happen when you get to the theatre suite. Basically, you have two choices. We have a general anaesthetic or a spinal anaesthetic, and we'll look at each of these two in a little bit more detail now. So a general anaesthetic is what people tend to expect when coming into hospital for an operation, that they go off to sleep, they're sound asleep for the operation, and then wake up again when it's finished. The advantages of that is that you will be unconscious for the whole of the operation. Disadvantages, though, are you may feel sick afterwards. Again, that can be treated with anti-sickness medication. You may have a sore throat afterwards. That can be treated with pain relief drugs. You may be more prone to a chest infection afterwards, which can be treated, but all of these things may delay your recovery. Spinal anaesthetic, this tends to be the preferred choice for this procedure. In excess of 90% of hip and knee replacements are done with a spinal anaesthetic these days. Your anaesthetist on the day will go into more detail with you of what's involved, but essentially a spinal anaesthetic is an injection that goes into your back and it will make your legs numb and heavy for up to 3 hours so that you will feel no pain during the procedure and the procedure can be done entirely this way. You can either stay awake during the procedure or if you prefer to, you may have some sedation during that time. If you opt for a spinal anaesthetic, I will explain briefly what happens, though your anaesthetist will go into more detail on the day. When you come to theatre, you'll have all the routine monitoring put on and you will have a drip inserted. The anaesthetist will then go and wash their hands while the anaesthetic assistant will position you usually as the illustration on the right here. So you'll be sat on the operating table in the anaesthetic room with your feet on a stool. Main difference being, you won't be stripped off as this patient is, you will still have your gown on and be covered. The skin will then be cleaned with some cold spray. There will be a sharp scratch and a little bit of stinging while some local anaesthetic is put into the skin. Then the block is inserted. First thing you usually feel after that goes in is that your bottom gets warm or your toes get tingly, and then they'll position you back round onto the table. So the advantages of the spinal anaesthetic compared to the general anaesthetic is you remain in control of your breathing and your cardiac function to a great extent, which means that you will be breathing for yourself throughout the procedure and will breathe better in the first few hours after your anaesthetic. This means that you'll be less likely to develop a chest infection. You will be more comfortable immediately after the operation in the recovery area. There's a reduced incidence of blood clots in the legs and therefore blood clots that travel to the lungs. You'll be less sick and drowsy after the operation, and you'll be able to eat and drink sooner. In fact, the vast majority of our patients who have their surgery done with a spinal anaesthetic are able to have a drink of water in recovery. Like anything, there are some disadvantages with the spinal anaesthetic. Your legs will feel heavy for the duration of the block. So for that 3 hours while the block is working, you may well not be able to move them. There is an increased risk of being unable to pass urine freely afterwards for a few hours, so you may temporarily need a catheter. Because of the way that the spinal anaesthetic is inserted, there is about a 1 in 150 risk of having a headache afterwards, and there is a 1 in 25,000 risk of having some nerve damage. If this is something that concerns you, then your anaesthetist can go into this in greater detail on the morning of your surgery. So the anaesthetist, after taking your medical history, looking at your drugs, will have a discussion with you and make a recommendation as to the type of anaesthetic that they feel would be best for you. At the end of the day, the choice of anaesthetic is yours. The anaesthetist will never force you to have one form of anaesthetic over the other. They may strongly recommend one because of something in your history, but generally, if they are happy that you have understood the implications and the risks, they will go with your wishes. So the anaesthetic visit on the day of surgery is a good time to ask questions of the anaesthetist and to express any concerns that you may have. Very, very occasionally, we may have to delay your operation. This is usually done after pre-op before you get into hospital. But if something has changed between your pre-op visit and you coming into hospital with your health, or if you are acutely unwell with something, it may be that your surgery has to be postponed. That will only happen if we feel there is something that can be done to improve your health, or if we feel that you have such high risk, you need a bit more time to consider whether you wish to proceed with the surgery or not. So thinking about pain relief after surgery for hip and knee replacement. There are various methods of treating the pain after your surgery. We can include some simple but significant measures, such as non-drug measures, which may include positioning. So something as simple as a pillow under your knee if you've had a knee replacement surgery, or the use of ice packs. We can also use, obviously, some drug methods. So these can include local anaesthetic, which will usually be administered at the time of your surgery. Afterwards, back on the ward, there are various drugs we can use. So we will use these in combination. They include drugs like opioids, anti-inflammatory drugs and their subclass, the COX-2 inhibitors, paracetamol, occasionally some anticonvulsant drugs such as pregabalin, and some antidepressant drugs, though those are used less these days. Patients will be prescribed regular paracetamol to be given at set times on the drug ward rounds. You will also be prescribed medication from the next rung up, so the stronger pain relief, which is usually opioids. Some anaesthetists and some surgeons prefer that you are prescribed modified release medications of this twice a day, with additional prescribed for what we call breakthrough pain, so as and when you need it, you can request it. Some anaesthetists will prescribe opiates as a modified release preparation, so it will be prescribed twice a day, with additional faster acting prescribed for as and when you need it, so you can ask the nursing staff for that. You will also be prescribed a regular anti-inflammatory drug unless you are unable to tolerate these. Patient-controlled analgesia, or PCA, is a form of pain relief that is rarely used today because it comes with some quite serious side effects and also limits the ability to mobilise early, which obviously is something that we are keen for you to do. So side effects of the analgesics occur mainly with the opiates, the strong painkillers, and can include nausea and vomiting and constipation. We can and will prescribe drugs to counteract those effects if you have them. Patients who have not previously had opiate drugs, so are not used to codeine or other medications like that, may find that it makes them drowsy, and in some rare cases it can produce hallucinations. If you have any of these side effects, inform the nursing staff. You can be given drugs to counteract the side effects, or the drug can be changed. At your anaesthetic visit on the day of your surgery, your anaesthetist may also inform you that they will administer a nerve block along with either your general or spinal anaesthetic. A nerve block is where local anaesthetic is deposited close to some of the nerves that supply the joint that is being operated on. They may help pain relief, but they don't usually provide complete pain relief, and they may or may not be appropriate for all procedures. Your anaesthetist will inform you beforehand if they intend to carry out one of these blocks. All patients will have local infiltration at the time of their surgery, so the surgeon will administer this around the hip or the knee joint. It'll give pain relief that can last for up to 8 hours and is much more commonly used than nerve blocks. So after your anaesthetic visit in the morning, when you're ready to come to theatre, you'll be escorted down there into the anaesthetic room. In the anaesthetic room, you'll be met by your anaesthetist and your anaesthetic assistants. Once you have your monitoring on and you have a cannula in place, there will then be further safety checks completed to ensure that we have the right patient, the right operation. Your general or spinal anaesthetic will then be administered, and the important thing to remember is the anaesthetist will be with you throughout. You don't have to remember everything you've been told from the anaesthetic visit earlier in the day. All instructions will be reiterated to you. Once the anaesthetist is happy that you're under general anaesthetic or that your spinal anaesthetic is working, you will then be wheeled into theatre. Obviously, you will either be awake or asleep, depending on whether you have chosen to have sedation or not. The anaesthetist will always be with you. Surgeons are fully covered at all times to avoid infection, and you will be covered as far as possible according to your surgical site to preserve your dignity. If you choose to be awake, there will be a screen in place so that you do not have to see what's going on. And if you have sedation, you are unlikely to hear any of the noises. At the end of your procedure, you will go into the recovery area where the nursing staff will continue to monitor you for your heart rate, your blood pressure, your oxygen saturations. If necessary, they can administer some more pain relief for you. If you've had a spinal anaesthetic, you may even be able to have a drink of water at that point. They will check your dressings and check your wounds, and then when they're happy that everything is settled, they will send you back to the ward. After surgery, you can eat and drink normally, and you will be encouraged to do so. The nursing staff on the ward will continue to monitor your heart rate, your blood pressure, your oxygen levels. You will probably have calf pumps on your leg, which will go up periodically to aid the circulation and try and prevent blood clots. Deep breathing is encouraged. You will be given foot and ankle exercises by the physiotherapists. If you've had a knee replacement, you may be asked to start bending your knee. You will be mobilised as early as possible and given physiotherapy. So the key things for success, as I said, Eat and drink early and try and exercise and mobilise as early as you can. Keep on top of your pain by taking the regular analgesia and asking for the additional analgesia as you feel necessary. You don't get any extra brownie points for suffering. Mobilise early, and hopefully all of these measures will lead to early discharge, because we know patients recover better at home than they do in hospital. So finally, the thing to remember, you're coming into hospital well, you are well before surgery, and the important thing to do is to take charge of your anaesthetic and your recovery. Thank you.
My name's Colin. I'm one of the nurses on the orthopaedic elective ward, and I split my time between the ward and joint school. I'll go through what you can expect when you arrive on the ward, ready for your surgery, and I'll go through the process from being admitted into being discharged home. So you're going to be admitted for joint replacement surgery. Admission to the elective ward, what we ask you to do is to bring in all of your medication. We do need them in their original boxes, and if you can bring in 7 days supply, it's just so as we can check that you've got the correct medication with you. Clothing for a couple of days. If you're having a knee replacement, shorts and t-shirts are excellent. Something that's light and loose, and any toiletries that you may need. You'll be given relevant staffing instructions prior to your admission, and they do ask for you to have a shower or a bath the evening or the morning of your surgery. When you do arrive, once the paperwork has been completed, they'll ask you to get into a theatre gown, and then we'll wait for the theatre suite to give us a call. We will check your temperature, blood pressure, your breathing rate, all things that we class as observations, just to get as a baseline for you. Blood test, they will be done when you arrive, and one of the consultants will put a pen mark on your leg. Once you're ready for theatre, the anaesthetist will come and see you, go through their checklist as the nursing staff will have gone through theirs, and then a member of the team will escort you to theatre. How you get there is entirely up to you. Theatre suite is about a minute's walk away from the ward. A lot of people walk simply because they can and they prefer that rather than go down in a chair. But if you do need assistance getting to theatre, just let the ward staff know and they'll arrange a chair to get you there. Safety checks are done prior to going to theatre. So what we do is we check that you've signed a consent form for the correct leg, and your consent form is correct and all the documentation supports that. We do all the checks on the ward. The surgeon will quite often come and put a pen mark on your leg with the initials THR or TKR for total hip or total knee replacement. And then when you get to theatre, one of the theatre staff will again check your consent form and make sure that the pen mark is on the correct leg. And then they quite often do it again in the anaesthetic room. In the reception part of theatre, you will be met by one of the recovery nurses. That nurse is assigned to your care during your time in theatre. The nurse will follow you through your surgery to recovery, and the whole idea is waking up to the same nurse. It makes people feel a bit more at ease. So this is one of our theatre suite. Around the roof there is a glass cage, and that's part of an air filtration system, and it scrubs the air entering theatre. Air flows one way, and it's all designed to reduce the risk of infection. We like to maintain dignity as much as we possibly can. False teeth, wigs, hearing aids, they can all be worn to theatre. If and when they need to be removed, they are in the anaesthetic room, and then given back to you as soon as you go into recovery. And it is the responsibility of the doctors and the nurses in theatre to maintain your dignity at all times. After your operation, you go into recovery, and they do quite close monitoring in there. It's quite commonplace. It's quite a large room. There may be more than yourself in there being recovered, so you hear lots of chatting going on, but it's all designed to keep you at ease. They will check your blood pressure, the oxygen levels in your blood, and also your temperature. You're never left on your own, and they're ideally placed to give you some extra medication should you need it. You will feel some pain after this surgery. Once the anaesthetist is happy with your recovery, then you are able to leave the theatre suite and return to the ward. The theatre staff will hand over to the day staff, the ward staff, and then they will take over your care. We will regularly check your blood pressure, your pulse, temperature, your breathing, and again, like I said earlier, what we refer to as observations. Once on the wards, we'll encourage you to repositioning, deep breathing, foot, ankle exercises, just to help with the blood flow in your operated leg. It helps to prevent things like blood clots and pressure sores on your heels as well. Passing urine, if that is an issue and you can't get to the bathroom, we've got urinals or commodes that we can use. We very rarely need to use catheters because they're a risk of infection. They're usually the last resort. We do try to get you to the bathroom though. Sometimes people feel a little bit faint and a bit nauseous when they come back from theatre, but that's relatively normal. That's what we expect. And there's medication that we can give to alleviate that. We also like to give you extra tablets after your operation, so things like laxatives because you are prone to constipation, and antiemetics if you're feeling a bit nauseated. And your consultant will come and see you, and ideally, if you're having a knee replacement, they like you to be up after 2 hours and a hip replacement after 4 hours. So day one after surgery, a wash at the bedside, or if you're feeling okay, we'll get you through to the bathroom. Breakfast is usually quite early in the morning, about 7:30. We'll get rid of all your attachments, so your blood pressure cuff, the finger probe for the oxygen levels, anything that can be a trip hazard, we tend to move out of the way just to maintain your safety. Pain relief drugs around will normally come around about 8 o'clock in the morning. But if you need any pain relief before that, just let the staff know because there should be something that you can take. And then it's up in the chair. We'll continue to check your observations. We do them quite regularly. The consultant will come and have a chat with you to let you know how theatre's gone. You'll have blood tests and an x-ray during that day. And then you'll be encouraged to mobilise with the nurses and the physios and to do your exercises that you'll have been shown. On day 2, again, it's pretty much a rerun of day 1, up and washed in the bathroom, dressed and breakfast, continue to practice your exercises with the physios and with the nurses. Walking will increase the distance and they'll offer you stair practice as well. We'll keep an eye on your wound. Knees are quite easy because we can see them. Hips are a little bit more private, but we just need to make sure that the dressing's clean and dry. Continue to do your observations, and there's certain blood tests that we might need to repeat on day 2, but not always. And then day 3 is day of discharge. You'll be discharged from hospital when the team are happy with your progress. So we need the physio to let us know that you are safe. We need the occupational therapist to tell us that you've got all of your equipment, and then the nursing staff will notify you when you can be discharged. Before you leave, the nursing staff will ensure you've got all your correct medication, but we'll go through your pain relief and your blood thinning products. Dressings, we'll make sure you've got a letter to give to the district nurse when they visit. And then you'll normally have an appointment between 6 and 8 weeks after surgery to see the consultant. Pain relief after surgery can be provided in different ways. We use tablets, capsules and liquids. It's different for everybody. We all feel pain in different ways. Some people don't have any pain following surgery and others do, so we can never tell. But there are a lot of medications that we can give. We also do a drug round 4 times a day on the ward. At each one you'll be offered pain relief. Please take it, because if you're in too much discomfort, you're not going to want to do your exercises, which will slow down your recovery. Apart from the 4 times a day that we come around with the medicines, you can also have medication for breakthrough pain. So in between those 4 times, you can also have pain relief, so just ask the staff. We also use non-drug treatments, something just as simple as repositioning, because you start to feel a little bit stiff. And ice packs are excellent. We use them for knees especially, but there's no reason why you can't put an ice pack against your hip area. And it just cools the hip down or the knee and helps to reduce any swelling and bruising. So the key points to remember, like I said, bring 1 box of each of your medications in with you, so we know that they are your tablets. Please don't use pill pots that we normally use, because we have to identify the drug, the dose, that they're in date, and they are actually yours. You can bring electronic equipment with you, such as a phone or an iPad. If you're having a spinal anaesthetic, you can take a radio device into the theatre with you, so you can listen to your own music if you so choose. Visiting is in line with hospital policy and is also at the discretion of the ward sister, and you'll be given the phone number for them in your paperwork. Try not to worry. All of the staff have been around for a long time, looked after an awful lot of people having hip and knee replacement surgery, and they're there to support and to guide you through your recovery. And if there's any concerns at all, that can be addressed, and the phone numbers will be in your information packs. Thank you.
Hi, my name is Phyllis Hughes. I'm Orthopaedic Discharge Support District Nurse. So I'm here just to give you a little bit of information about the service that we run alongside the orthopaedic team here at the Wrexham Myler. We're actually district nurses, but we cover Wrexham and Flintshire. We're based at Wrexham Myler Hospital, and we work through Monday to Friday. But in saying that, you do have covered 24 hours, 7 days a week because of the district nurse service that's out in the community. So if I was to have any issues, or you would have any issues, we would have a contact number that you could ring to get support over the weekend. Contact details are on the screen, but you don't need to worry about writing those down. We will give you those on a little leaflet once you're being discharged from the hospital. Now, what's our role? We're here to provide ongoing care following your admission from the acute into the community setting. A few years ago, you'd have probably been in for over a week. Before that, maybe even 2 weeks, but now you're in and out in 1 to 3 days. So it's very important that you have that care in the community once you're discharged. When we come and visit you at home, we carry our own sanitising equipment, so you don't need to worry about providing anything. Now, we work alongside the multidisciplinary team, so we're here to liaise with physios, OT, your consultant, the ward staff, just to make sure that everyone's aware and we can continue that link from the acute into the community. We also carry out clinical procedures. That sounds very dramatic, but it's basically looking after you once you discharge. Your wound care, any bloods that need doing, anything clinical, we'll do that in the comfort of your own home. And the big thing we do is provide support and advice. You will get a lot of information thrown at you today when you come in, seeing a lot of different people, and it's really important that you get some of that information and retain it. But if you don't, you have a contact number that you can give a call to and just get that information reinforced. So we're there at the end of the phone. So a little slide shows you that we try and provide a seamless service. It doesn't always work out. Sometimes we have little hiccups, as you can see with this slide, but generally they're only very small things and we get over them quite quickly. So how do we do that? We'll see you in joint school. We have a chat, we go through things with you, you meet the team, and then we come along and see you on the ward once you're admitted. Usually before you have your surgery in the morning, and then we'll see you after your surgeries. Now, you're a very important member of the team, so your role within the team is to ensure that we have an accurate address. And you'd be surprised, you might think, an accurate address, but you'd be surprised at the number of people that have moved house and not changed the details. Or it could be that you're actually staying with someone else on your discharge, a family member or friend. If it's within our catchment area, Wrexham and Flintshire, that's not a problem, we'll still come and see you. But if you're actually staying outside our catchment area, say in Cheshire, you would need to register with that person's GP. So the district nurses within that team would be able to follow up with your care. Please give us any directions if you've got a lovely house name, but it's up a lane and down a road and very difficult to find. But you can do that when we come and see you on the ward. And also we'll ring you on the morning of the first visit. We just ring, say hello, reintroduce ourselves, and it could be that maybe you've forgotten your dressing gown or a charger of some sort for your phone or your razor. That's your opportunity to say, well, actually, listen, Phyllis, I forgot this, it's on the ward, and we'll bring it with us whenever we come to see you. Concerns with visiting is usually things like if it's knees, maybe you have a physio appointment that's going to clash with when we're visiting. I've had one of those today. Person's going in the afternoon, so I go and see them in the morning. And it could be that you have maybe a couple of dogs that need sort of putting out of the room because they're not happy with people coming into the home. So we would ring you and let you know when we're coming, so as you can arrange that. So anything at all, any concerns with visiting, if you let us know, then we're aware of it and everything then goes smoothly. Now, this little slide is telling you about Clexane. Clexane, what is it? It's an anti-coag that's administered via an injection. Anybody that's having orthopaedic surgery or abdominal surgery, and it makes you less mobile than what you would normally be, then they have to have some sort of anti-coag. Consultants prescribe different things, and everybody's an individual, and it depends on what their medical history is. Some people have a little tablet that they take twice a day. It really does depend, and some people are already on warfarin, so everybody's different. But if you're prescribed Clexane, then what we'll do is we teach you how to do that yourself. So you get an opportunity on the ward to practice that prior to your discharge, and we support you with that at home. Now, if you have got Clexane, we tell you that it's only administered in the tummy. It's not licensed for the arm or the hip or anywhere, so it's only in the abdomen area, and you need to alternate sides. Left side one day, right side the next. So you need to watch out for things like bruising because it is thinning your blood. So if you were peeling potatoes and cut yourself, it would bleed a bit more readily than it would normally. So you'd have to apply pressure for a little bit longer. And we say to you, make a note of your injection site, because you do it on the left side and then you go to bed, get up the next day and you think, where did I do my injection yesterday? So it's important that you make a note on your calendar, one, that you've actually done it, and two, which side. So you can tick it off every day and you know that you've actually completed that. We also give you a yellow box home with you, which is a Sharps box. And that in Flintshire area, they're picked up. We give you a number to ring. And in Wrexham, we say drop it off at your local district nurse clinic. Again, any concerns with that, just give us a ring and we'll keep you straight. Now, finally, it's just a conclusion, really. Feedback's very, very important. This service has been running for quite a long time. It's important that if there's any concerns or if there's any questions, it's lovely to get good feedback, but if you have any concerns, then we look at those as well and we can actually improve our service accordingly. So thank you very much for listening. I look forward to seeing you all when you come in for your surgery.
Hi, my name's Cindy and I'm one of the physios that work here at the Wrexham Hospital. Following your surgery, you'll be seen by one of the inpatient team who will guide you through your rehabilitation process. The role of the physio following your knee replacement will be to educate you about your surgery, to provide you with an individualised exercise programme, to provide you with an appropriate walking aid, show you how to use that walking aid so we can restore your function and mobility to promote early return to independence. On the day of your surgery, you'll be admitted to the orthopaedic unit. We'll reinforce the information we're giving you in this video. We'll check your exercises, make sure you're happy with them. We'll assess your mobility with an appropriate walking aid, and we will practice stairs or step if appropriate. We'll also check your details to make sure that we've got the correct address for an outpatient physio referral. On the day of your surgery, you will be sat out in the chair, normally 2 to 3 hours on your return to the ward. You'll start mobilising with an appropriate walking aid and we will start your exercise programme. The exercises are aimed at improving your circulation, improving the range of movement of your knee and strengthening the muscles around it. On subsequent days, you will progress your mobility with your walking aid. Initially, that will be with a Zimmer frame, but then progress you onto crutches if that's appropriate. You will start ice therapy. Ice therapy helps reduce some of the swelling and take some of the discomfort away. And it's important that you continue with the ice therapy once you've gone home. You'll continue the exercise programme, and we will practice the stair or a step with you before you're discharged. We will also make that outpatient referral to your local hospital. Milestones for your discharge from a physio point of view will be you need to be independent with your walking aid. You need to be able to get on and off the bed and on and off the chairs independently. You need to be able to negotiate the stairs or steps safely. And your knee needs to be moving from 0 to 90 degrees. That is a functional range for you. Things to remember: your visiting may be interrupted. It's important that you're seen by a physiotherapist, and apologies in advance if your relatives are there visiting you, but it is important that we see you. Remember to take your pain relief regularly. Orthopaedic surgery isn't gentle by any stretch of the imagination, so it is important that you take your pain relief so that you can do what we ask you to do. Be motivated to exercise and walk regularly. Little and often is the key. Continue with your ice therapy to reduce that swelling. 20 minutes every couple of hours helps to take that inflammation down. Be guided by your knee. You're going to have good days and you're going to have not so good days. But we hope as your rehabilitation progresses, those good days will improve. And if you can begin your knee exercises before you come in for your surgery, all the better. Your knee will be stronger and you'll be familiar with your exercises.
Hi, my name's Nicola. I'm one of the occupational therapists at Wrexham Hospital. I'm just going to go through a presentation with you about total knee replacement and what to expect from an occupational therapy point of view. So the role of occupational therapist is to look at how you're managing your activities of daily living. So from getting up in the morning, getting washed and dressed, to making your meals, how you manage to get on and off the bed, chair, toilet, and also looking at any equipment that might support you at home to increase your independence. So when you come into hospital, one of the occupational therapy team will come and see you on the ward and discuss home environment. We'll discuss how you manage your activities of daily living, and we'll also discuss social support. That would be something for you to have a think about before you come into hospital, to see if there's anybody who can help you with things like your shopping or housework after surgery. After you've had your operation and you're up and about, you're mobilising on the ward, one of the occupational therapists will come and assess you. We'll see how you are managing to get on and off the bed, chair and the toilet. We'll be able to identify any equipment needs and provide the equipment. So washing and dressing after surgery. You are able to shower following your surgery, providing that you have a waterproof dressing. Alternatively, you may want to have a strip wash at the sink. We'd advise you to dress whilst you're sat down on a suitable height chair or bed, and we always say to dress your operated leg first. If required, dressing aids can be provided, so let one of us know. We do ask that you bring in good footwear with you, something with a back on it, so that you can mobilise safely on the ward. So driving after surgery, we say to check with your consultant and also to inform your insurance company. The main stipulation is that you must be able to do an emergency stop, so getting full force down onto the pedals with both legs. So advice for returning home. We ask that you remove any loose rugs or matting and ensure there are no trailing cables. This is to reduce your risk of falls or trips. We also ask for you to consider having a light next to your bed, so that when you get up during the night you can pop it on to make your way safely to the bathroom.
Thank you for watching our videos about your stay for your operation. We hope to welcome you to the department very soon.